Great. Hello, everyone. I am Martin Lau, dietitian and services development manager here at Arthritis Action, and welcome to join our webinar, Pain Explained, Medication, Management, and More. Today, I am joined by Catherine Dyer, lead nurse and matron at the Pain Management Service over at Norfolk and Norwich University Hospital NHS Trust, Dr. Wendy Holden, consultant rheumatologist and Arthritis Action's medical advisor, and Heather Bilmo-Johnson, director of services and operation, again here at Arthritis Action. Hi, Catherine, Wendy, and Heather. How are you all today?
Good.
Very good.
Excellent.
I have a little croaky voice, so I do apologise for that, but I'll do my best.
You'll be fine. Now, is it possible to tell our audience a little bit more about yourself, starting with Catherine first, please?
Yes, of course, Martin. I've been working for a pain management clinic for over 20 years, and my passion is trying to explain to people how best to live with long-term pain and do all the things that they really find valuable in life. So I'm looking forward to lots of questions today.
Fantastic. Wendy?
Hi there, I'm a medical advisor to Arthritis Action and I'm a consultant rheumatologist, and I'm also really interested in pain, but it's such a treat to have Catherine with us here today, who's somebody on the front line of pain management. So I'm sure she's got loads of tips for us.
Fantastic. And finally, Heather.
Hi, yes, I work with Arthritis Action and I'm also a clinical hypnotherapist. And so pain is one of my interests, to try and help people, relieve people from the stress and the feelings of pain.
Thank you. Well, thank you, all of you. Now, if you have any further questions you would like to ask us during the webinar, please click on the Q&A button at the end of the screen and then type in your question. And then if time permitting, we will be able to answer it at the end of the webinar. Now, if we do not have time to answer all your questions, we'll answer them via email from Catherine or Wendy or even Heather after the event. If you will also be, well, we're probably going to ask you, if you wouldn't mind, sending us the questions via email, it would be useful. But we will also be sending you an email with further resources and information after this event. Now, before we start, I would like to remind you that this webinar is not intended to be a substitute for medical advice. Always seek guidance from your doctor or other healthcare professionals with any questions you may have regarding your medical condition. Now, without further ado, let's proceed with today's webinar. Over to you, experts.
Thank you, Martin. The first thing we're going to talk about today is trying to understand pain a bit more, and to look at the first section is pain mechanisms and what is that. And Catherine, can you explain to us a little bit more about that, please?
Yes, of course. Thank you, Heather. So pain is a really important mechanism. We all need to be able to experience pain. In the first instance, we often talk about the difference between acute and chronic pain. And acute is something that's a warning. It's an alarm bell. It serves us as a protective function. It stops us. So if I'm having a heart attack, I need to know quickly that I need to get medical help. If I burn myself, I cut myself. So in medicine, we often talk about an acute and a chronic phase where something develops over time. So acute pain, it serves as a protective function. We know what we've done. We've tripped over a football or the dog or the cat. And we know that if we take regular painkillers, we know that for most types of that acute pain that they work very well. But unfortunately, as time goes on, for some people that pain doesn't go away. And that often then leads into a condition called chronic pain. So some people prefer the word persistent, some people prefer the word long-term, but we're talking about pain that for most people has gone on for three plus months. And that pain becomes a bigger beast. And all of you, I'm sure, will have experiences of living with chronic pain. And we know that medication is less effective. We know that it has a bigger impact on the other aspects of health and lifestyle. The most important thing to remember is that it's no longer a sign of ongoing damage. So you're not damaging yourself. It's a long-term feeling that you're feeling. So I think it's important to think about that there are lots of different types of pain. We can get pain from our joints, as in arthritis. We can get pain from in our muscles, and all over really. And different types of pain have different names. And there's some big words on this diagram here, but it tries to explain that there are different types of pain. Nociceptive pain is that pain that is done to damage joints, muscles, organs. So if you burn yourself, you cut yourself, you break a bone, then the pain is likely to have some of that nociceptive element. So nociceptors are the receptors that pick up the pain information, and we know that that information gives a particular type of aching or throbbing pain. Some conditions, there is more emphasis on the nervous system, and the pain comes directly from damage or irritation from the nerve fibers. And that might be in something like diabetic neuropathy, where patients with diabetes get altered sensations and altered nerve pain because of their diabetic condition. And then there's the third type, the type that sort of goes alongside and affects things like the nerve fibers, but long after damage is gone, that information, that central nervous system that builds the electrical information through the brain, and it all in a real mixture really. So 3 different types of pain that all have slightly different mechanisms and also slightly different ways of treating them, particularly from medication. And for many of you, I think the reality is that you may well be suffering from that mixed pain state that's in the middle of that diagram there. You might have a low back pain, you might have pain in your hip, you might have a neuropathic pain, and all of those mixed together can be very complex. I think Wendy is going to talk a little bit particularly now about arthritis pain.
Yes, so here's a picture of a joint. The creamy bit in the middle, that's the bone. The dark blue there is the lining of the joint, which is the cartilage. And there are other pain sensitive structures around the joint. So for example, the capsule and the ligament in the joint. Now, if you fall over and you say you injure your ankle or you injure your knee, you often might have actually done some physical damage to the ligament or the lining of the joint, and that will give you that sort of the pain nerves in that area will immediately fire and cause that throbbing type pain that you get, the pain that wakes you up at night, and that's the nociceptive type of pain. In addition, around the joint, you've got little nerves that can then start to fire. And in osteoarthritis, where there is wear and tear in the lining of the joint, some of those pain nerves can become very, very sensitive. And you can have an element of neuropathic pain as well. Now, once the damage in the joint has healed, the joint should no longer be painful, but it is for many people. And we think that is because something happens in the nervous system, especially in the brain and in the spinal cord, where the pain sensitive areas become turned up, if you like. And that's the nociplastic pain that Catherine was talking about. Now, there's one really interesting thing in this diagram I just wanted to mention, which is that traditionally osteoarthritis has been called wear and tear, and that means wear of the articular cartilage, the blue layer. And people think that that is often what causes pain, but in fact, the articular cartilage does not have pain receptors in it. You can't feel pain in that area. And we know that because volunteers, well, I think they were volunteers, let themselves undergo experiments where surgeons put probes inside their joint to see which parts were painful. And when they stick basically a dirty great needle inside the cartilage of the knee joint, it doesn't hurt. People don't perceive pain in that area. So actually the cartilage of the joint does not cause pain. It's all the other structures around the joint and the brain that goes wrong in osteoarthritis pain.
Okay, thank you, Wendy. That's a good explanation of why arthritis is painful. We've had a couple of questions, and I just want to say to Holly, we will talk about the recent reports about NSAIDs and in the next section. So we'll try and answer that at that point as to what, you know, why possibly that decision was made by NICE. And Pauline, I think this is probably a problem that you've got that we'll have to respond to separately, because I think it's important that you get an answer if it's possible for us to give you one. Okay, we'll contact you later. Thank you. So Catherine, why do some people get more pain than others, and why does pain persist?
So I'm going to start just briefly by explaining what pain is. Pain is an electrical message that travels from the area where you get the pain, say from, in this example, from your knee. Electrical information in those nerve fibers that Wendy explained about travel through the outer nervous system into the central nervous system, into the spinal cord. And then on up into the brain, where various sections of the brain process and understand what that electrical information is. And remembering that our body they are a complete motorway of nerve fibers all running throughout the body, giving us lots of information, not just about pain, but about all everything else that we feel, we experience. So there's lots of electrical information that travels up to the brain. And we know then that it's only once that electrical information gets to those centres in the brain that actually our brain starts to interpret them as pain and identify them differently than other electrical impulses. And that we also know then that our brains have a marvellous way of altering or changing some of the electrical information that comes back through the spinal cord and back out to the knee joint where that pain originated. And so we know that there is a motorway, a two-way motorway really, of information going through the nervous system and then back out of the nervous system. And what we know is that both those upward and downward messages are really important in processing and experiencing pain. We know that persistent or chronic pain is much less about recurring or ongoing damage, but it's more about the interruption and sensitization, as Wendy talked about, of the nervous system. And most importantly, remembering that we talked at the beginning about how our brains process acute pain. Acute pain's an alarm bell. So in the first instances of pain, when we experience pain, we're worried about harm. We're worried about something that's going to hurt us, something that's going to damage us. And so we actually can have quite a lot of influence in those things that help us or help us change the influence of the experience, how we change the experience of that pain. So we often talk about thinking about for ourselves, thinking about things that make our pain better, things that make our pain worse. And Heather, this answers your question. Why are there things that make my pain better that don't work for someone else? Or why has my pain gone on that bit longer? And if we think about this dial, what we're hoping for in this dial is realizing that our experience is like a voltmeter, that as the number of negative things come in, the risk is that our voltmeter goes up and up and up, and our pain levels go up and up and up. And so thinking about what makes your pain better and what makes your pain worse can be very useful in trying to understand just how managing pain as a long-term condition can be quite difficult. So I'd like you just to have a little bit of a think. I'm sure there are things that you will all do or try that will either help or that will make your pain worse. So I wonder if you could just take a few minutes, just have a little bit think about your experience of pain. What makes it better and what makes it worse?
I'm writing mine down, Catherine. Is that all right?
That's fine. That's fine. One of the downsides of screen sharing is that you can't see the chat and the questions. So I'm relying on all the others there to point me in the right direction if anything happens. I don't press another button in case I give away the answers, which are on the next slide. So I wonder if I can put you on the spot, Wendy, Heather, Martin. Perhaps you could do some call outs either from the chat room or from your own thoughts and experiences. What things either make your pain better or make it worse?
Carrying a heavy shopping bag and walking for too long makes my back worse.
Okay, so walking too long and heavy shopping on the worst side.
Yes.
Yeah.
And on the good side, heat.
And heat on the good side. Yeah. Yeah.
I've put what makes it worse are feeling tired and feeling stressed.
Yeah.
And what makes it better, being with my friends and feeling more relaxed.
Okay.
I've got some, I found a few messages from the chat box from our audiences. So
Brilliant.
I'm going to read some of them out.
Thank you.
Walking make it worse, and resting or use of heat and making it better. Movement is another one. Somebody said that certain foods make it worse. Hot, humid weather makes it much worse.
Okay.
Cold weather makes it worse. And then not moving around makes it better, but it's also making me worse. And being in a relaxed, happy environment, it makes it better. Overthinking makes it worse. Yes, definitely something that it can cause a lot of problem in terms of the threat side of things. Positivity is a great distraction. Exercise and heat makes it better, and distraction, I take it as making it as a sign of safety. Okay.
Brilliant.
Overdoing it makes it worse. Yes, yeah, this is quite a common one.
Yeah, definitely. Yeah. Well, thank you so much. I can see the numbers of people in the chat room responding, going up and up and up. That's really fantastic because I think it's really important to be able to identify how pain affects you personally. That's so important that when we're talking about you and your experiences. So I'm just going to move on to my next slide, which has a little bit of a look at some of these things. So lots of you talked about, I'm interested in the one about the weather. I think we should all move to somewhere really hot, but maybe not humid, because somebody said that humidity made it worse. So, but if you'd like to take your pain nurse with you to the hot place, then I'm very willing to come with you. But interesting how so many of the experiences you've had can be on the positive and on the negative. So exercise and movement can make it better, but too much exercise and too vigorous exercise can also make it worse. I suggest also too, inactivity, doing nothing for too long also makes it worse. So there's a lot of really positive things there. I think we've talked about positivity and positive mood and a positive outlook on life. I think there's lots about distraction and how having friendship groups or those enjoyable activities are really important. But we also know that there's always a flip side to those coins, and I think that's sometimes where we're likely to start feeling the difficulty, is that it's often too much, isn't it, or too little. And that's so often the case with lots of long-term conditions, that what works in the short term or in small amounts doesn't necessarily happen to work in the longer term. And I think it's very true to say that when you're managing pain as a long-term condition, is that you've all developed, over the years that you've had pain, you will have developed coping strategies that help you manage your pain. But if you rely on them too much, on that one thing that helps your pain, then maybe when it's not there anymore, it may start to have less of an effect. So what this is really saying is that our bodies are a permanent messaging service of information coming in and out of the nervous system that is upwardly moderating and downwardly changing our experiences of long-term pain. And the one thing that I think we're probably going to move on to fairly shortly is the effect of medication. Now, I think if we were to identify on this diagram, some of you would say that there is a role for medication, that medication helps, and that you found a medication that works really well for you. But equally, there are times when medication can have a negative effect, or a change in policy or prescribing suggestion changes, and that medication no longer works anymore. So medication, again, can sit on both sides of that that diagram.
Thank you, Catherine. There's two questions that we had beforehand, before the meeting, that people ask, and one is, why do my pains move around? So I don't know whether Wendy or Catherine, you can answer that.
Go for it, Catherine.
Thanks, Wendy. I think the reality is that we experience pain in lots of different places. We know that osteoarthritis affects different joints, in differing levels, and therefore I think we know that the nervous system, when it transmits that information, you can actually get pain anywhere along that nerve pathway. So the nerve in your foot, for example, that information goes all the way up through the back of your leg and through the front of your thigh and ends up in your spine. And it's not uncommon for people to get very different widespread pains. I think also too, pain moves around because often if you've got a very painful right hip, for example, your posture changes, your activity levels change, and it might be that you use a crutch or a walking stick in one hand or the other. And again, that in itself can lead to pain in those areas as well. Unfortunately, our bodies are always at their best when we sit up straight, we look like a textbook, and all the joints and muscles and organs all sit in the right places. And the reality is that as humans, that doesn't happen. And I think overcompensating with changes in posture can often cause other pains in other areas.
Yeah, thank you, Catherine. Yes, I've certainly heard a lot of people say that by using a walking stick or another aid, it can actually make a pain somewhere else. And I'm not saying don't use a walking stick if you need one, but do use it, but just be aware that it might just cause pain somewhere else. And then another question was, I'm worried because no one can see my pain, and I think people think I'm making it up. So it's about pain is pain, whether anybody else can see it or not, really. I don't know how you, Wendy and Catherine, respond to this in clinic.
I think it's clearly obvious that the pain is not made up, isn't it? People are incredibly disabled by long-term pain, and it's obviously not made up. I don't think it's family and very close friends that would say that, because they know how people struggle with living with pain. It's often people like employers, for example, or more distant people that say, well, there's nothing wrong with you, why have you got a disability badge? That sort of thing. So it absolutely, and unfortunately some medical professionals as well have been less than sympathetic historically sometimes. So obviously pain is completely real, and obviously you're not making it up. So anyone that doesn't see that, they're to be ignored, frankly, and eliminate those people from your lives.
I think the sad reality is that the majority of the population's perception of pain is something that you get in as a result of doing something wrong. You get pain, you take some painkillers and the pain goes away. And when somebody says, well, I've still got pain and I take painkillers, or I've got pain and I don't take painkillers because they don't work, I think society is a step behind when we're looking at managing pain as a long-term or a persistent problem. You wouldn't expect a patient with diabetes to be talking about the diabetes being fixed or cured. You would expect them to be developing management strategies to manage their diabetes. And I think society is yet to catch up. But it's not in your head. The only reason you need a head in order to experience and perceive pain, but it's certainly not something you've made up.
Lovely, thank you. We're going to move on to the section now about medicines and pain, and I think there's been quite a few questions on this as well. So I'm just going to give you the questions that people have asked to start with, and or maybe you can fit this into your talk when you talk about it. So one person was asking, how do steroid injections work? So maybe that's something you could pop in there. And then obviously the NSAIDs question, which came earlier. And also part of a question is that how can I probably assess, I'm sure what I'm dealing with. GP refuses to do anything, just recommends paracetamol and Voltarol, neither of which is in any way helpful. There is a pre-question to that, but I'm just interested in the paracetamol and Voltarol. How does that help at this stage? So if perhaps you can answer that in amongst the questions that you're going to answer, that would be great. Thank you.
Brilliant, thanks Heather. So I tell you what, Catherine, should we just talk a little bit about different types of painkillers to start with, and then we can move into the NICE guidelines, which have upset a lot of people. So first of all, we'll talk about anti-inflammatory, shall we, to start with? So they would be medicines. So for example, ibuprofen, naproxen, etoricoxib, they're all examples of anti-inflammatory medicines. So do you want to say a little bit about those to start with?
Yes, so anti-inflammatories, they do exactly what it says on the tin. They are anti-inflammatory. And if we know that you're suffering from a condition where there is inflammation, maybe around a joint, or then anti-inflammatories, they work by reducing the inflammation process, and they work by dampening down that swelling, reducing the swelling, and then hopefully then reducing the pain at the same time. The downside is that there are other aspects of the anti-inflammatory drugs where some of the side effects or the risk factors, we rely on the inflammation process in places like our lungs, our stomachs, to protect other systems. So, for example, there is one of the risks of anti-inflammatories is the effect that it has on your tummy. It can cause indigestion, but it can also develop into more serious conditions where the lining of the tummy is it becomes eroded because the chemicals there aren't there to protect the lining of the tummy. So that's where the difficulties are. But often used in patients with arthritis.
Yeah, I would agree. There was a question in there actually about, there was some publicity last week saying that anti-inflammatories might make things worse because the inflammatory process is sort of a natural process and it's designed to help us heal in some way. So there is this theory that perhaps if we use anti-inflammatories, are we harming ourselves? I think the jury's probably still out on that. I don't think there's any evidence that anti-inflammatories actually damage joints or make pain worse, but they do, of course, as you said quite rightly, Catherine, they have got all sorts of potentially nasty side effects, particularly on the stomach and the kidneys. And it's said that, you know, more than 1,000 people die every year from gastric related problems to do with anti-inflammatories, which are considered really safe because you can buy them over the counter, but that doesn't necessarily mean they're safe. Okay, what about paracetamol? That's usually the thing most people reach for when they've got a pain.
It is, isn't it? And yet it's one of those drugs we actually know very little about. So in many ways, it's seen as the safe option. As Wendy says, you can buy it over the counter. And we know that it has some anti-inflammatory bits to it. So it can help with inflammation. I think the risk with paracetamol is that it has other uses. So if you're reliant on regular paracetamol, I worry lots about what happens when you get flu or you get a cold and you want to take cold remedies. There is a risk with paracetamol of taking too much. It does have an effect on your liver. I think the reality with medication is that there is no such thing as a free or risk-free medication. My take home is always that if it's not doing anything, if it's not helping, then don't be taking it. Because there is evidence that suggests that paracetamol and can be as dangerous certainly to the older population. So I think again, it's about making sure that it's actually helping.
Yeah, I would agree with that. I'll answer that question about steroid injections now. So steroids are immunosuppressing drugs, which are really a powerful form of anti-inflammatory medication. So steroid injections are not painkillers in themselves, but they can calm down any inflammation that is being driven by the immune system inside a joint. So that's how they work. And there's a question there, does the panel have a view on Flexisec? Yes, I do. I looked this up the other day because somebody had told me it had really helped them rubbing it on their joints. And in fact, there are no active ingredients at all in Flexisec. So I can't explain that other than perhaps it's a placebo effect. Or maybe you could answer that, Catherine. It might be a rubbing on thing. Maybe you could talk about that a bit. Yes,
I don't have much experience of Flexisec, I have to say, but with the absence of any active ingredient, I would think that there are several things there. When we rub creams, or even if we just rub our joints or our skin, we know that we get warmth and heat. Remembering that, going back to that list of helpful things, heat was on there for many of you. I think sometimes massage and sort of rubbing can stimulate the nerve fibers in the skin, which can distract or interrupt the nervous system. So heavy rubbing of your skin can mimic the use of things like TENS machines that again stimulate the skin to produce fast-acting pain messages that block out the bigger messages. So I think there is probably something in there. I suspect that if you sit down and you rub Flexisec or any other cream on your knee, that means you've maybe reduced your activity for a little while. So maybe you're taking a break, taking a pause from your activity. So you've stopped, and for many people, they find it pleasant and enjoyable. And we know, again, that things that make up to us feel pleasant or enjoyable, we know that changes our experience of pain.
Absolutely. It's like your mum rubbing it better, isn't it? It's
yeah.
sort of just, soothing. Yeah. Absolutely.
Yeah.
Okay, so there's a couple of other questions there. So there's a question there about stomach protectors or proton pump inhibitors, such as omeprazole, to protect from anti-inflammatories. They definitely do have a protective effect to some extent, but many people can systems can still bypass that. So even if you're taking a stomach protector, you still have to use anti-inflammatory medicines with a lot of caution. So you can still get bleeds even if you're using those. Okay, so I guess we should move on then to the next, what used to be in the olden days, it was called the pain ladder, wasn't it? So it used to be put on an ever increasingly heavy dose of strong painkillers. So what comes then after in that ladder then after paracetamol and anti-inflammatories then, Catherine? This is a hot topic, isn't it?
Hot topic, because the next group of drugs are drugs like codeine or cocodamol that you can buy over the counter in low doses, codeine, tramadol, the use of patches or Butrans patches, through to things like morphine and other strong opiates. And again, over the last 10 years, I suppose we've started to become increasingly aware that overemphasis on one type of medication risks us our bodies becoming quite reliant or quite dependent on those medications. And again, they tend to have unseen side effects that if you're not careful, you then need another medication to dissipate the side effects. So opiates do have really bad press, and again, I think need thinking about in caution. There is limited evidence that the longer you've had pain, the likelihood is that opiates don't work very well. And I think the risk for medication is that it tends to be the one thing that your healthcare professionals are able to give you, and there is, I think, an overemphasis on using them sometimes. And I think finding a balance. Medication should always have some benefit in a physical or functional aspect, so it should help you be more active, do more activity, do more movement. Because there is no doubt with the opiate drugs, there are side effects. We know that over time, your body is likely to become dependent on them. So you will need more and more and higher doses in order to get the same benefit. And that does risk the risk of dependence and not being able to manage without them and feeling unwell when you stop taking them or are unable to take them for whatever reason.
Yeah, absolutely. And of course, opioids are not without considerable side effects in terms of, bowel health, constipation, mood and sleep sometimes. And most people don't like taking opioids long term for that very reason. So I think this kind of joins in nicely now with some of the NICE guidelines, and then we'll talk about what we should do for people who do find those medicines to be helpful, because obviously some people do. So we've recently read that just a couple of weeks ago that NICE have now downgraded their advice for people with osteoarthritis, for example, and they are no longer recommending at all, really, opioids for pain of osteoarthritis, and that ties in with the chronic pain guidelines for opioids as well. And they've also downgraded use of all anti-inflammatories and paracetamol for arthritis related pain as well. So what do you make of all of that?
I think if I was a patient sat here with long-term pain with osteoarthritis or having relied on medication for a very long time, I think I'd be really scared. I think I would be really worried. I would feel that I've been prescribed medication, some people for many, many, many years, and now all of a sudden, those same healthcare professionals are sitting there saying, oh, well, we're going to take you off those, we're going to stop those. And I can imagine if I go back to my safety and my threat voltmeter, I've gone right up into utter panic, I think. And even as a healthcare professional, I think it's really important we recognise that you've sat there and you've taken those medications with our advice for many, many years, many of you. And I think we have to try and help you to develop some of the other strategies that I think can work alongside medication to give you the confidence that things like managing your activity, little bits of exercise or movement, understanding your thought processes, unraveling those underlying mood issues and tiredness, and sort of giving people the other strategies. Because the one thing that I do think is that so many of the side effects of the medications, things like a sluggish bowel, a loss of libido or get up and go, not feeling sort of feeling sleepy and tired, but not, which isn't improved by sleep. Often all of those are actually side effects of the medications that you might well be taking. So to try and find that balance, to don't feel that your doctor or your healthcare professional is taking away that medication, but to try and supplement it and put less emphasis on medication on a long-term basis, so that if we can get into a situation of managing pain, the sort of everyday levels of pain using other strategies, when you have a flare-up of pain, which you inevitably will, then you can maybe then rely on some short-term medication that might help for a little while.
Yeah, that I would totally agree with that then Catherine. So there's loads of questions coming in on those topics. So for example, Deborah says, so what would you do for a RA flare-up? That's exactly what you just said, Catherine, then, wasn't it? It's about trying to reduce your medication on the fairly good days if you can, so that you can use it effectively when you have a bad pain day. So still continue to use that. And what NICE are now saying on the effectiveness of other things for osteoarthritis pain is that things like weight management and exercise are as or more important than all of the medication above, but just use your discretion with that. They're not saying don't use the medicines, they're just saying don't rely on them and do other things as well. Okay, so there was another question there about lidocaine patches, which is an interesting topic. So those are patches impregnated with local anaesthetic. Have you got some thoughts on that, Catherine? I've got some thoughts on that. You go ahead, though.
I think the risk with anything, the patches aren't that big, and a lot of people's pain is very widespread. And they are expensive, and I think they probably have limited value. But I think for a very small niche population, I think they can be useful in that they don't affect you systemically, so from the inside. So the risk of side effect is far, far, far less. But I think the reality is that, as far as I'm aware, I think they are 10 centimetres squared. So they are very small.
That's exactly right. And the other thing is the lidocaine will only penetrate a certain distance, won't it, through the skin? So it's not going to get to very deep structures. It might help if your pain is coming from something just below the surface. But the person who asked the question about those patches, why do GPs not prescribe them? And it's largely because they are A, expensive, and B, not really evidence-based treatment, although, as you say, Catherine, there are some niche uses for those. And I don't know if you found this, but I have found that they can be actually quite helpful if there has been a area of acute injury. So for example, a spinal fracture in the acute stages of that, but maybe not so good for chronic pain. Yeah,
absolutely. Again, it's a short-term superficial strategy, I think. And I think the risk is if we as prescribers, if we advocate too much of those sorts of things, I think we'll risk losing the ability to prescribe them for that very small population market.
Yeah, I agree. So there's a few questions there. Martin might like to join in on the end of this particularly. There's a few questions. There's one about collagen supplements. There's about food, and there was one about turmeric that I thought that he should probably answer at the end as well. And there was something about cannabis oils and CBD as well, which is our topic at the moment. And the answer to the question is you can't. Cannabis medicines are not prescribable on the NHS, and be careful what you buy over the counter, because cannabis CBD oil in particular is called a food substance, and it's not a medicine when you buy it over the counter or online. So it's not in any way regulated, and it may in fact contain THC, the active substance in cannabis. So just be careful what you buy there. Okay, I think, have we covered everything there on medication, do you think? Heather?
I think the bottom line possibly with medication is that there's no easy fix. Living with pain as a long-term condition is unlike, there is no miracle. If it was cannabis, if it was lidocaine, if it was drug X that they haven't manufactured yet, pain clinics wouldn't exist. You wouldn't be in the situations you're in. It's about thinking very carefully about, is the medication that you're on, does it work for you? And does the risk of long-term, short or long-term side effects outweigh that, the benefit that you're getting? But also,
sorry, carry on.
But making sure that if you do want a conversation about your medication, is that you do that with your healthcare professional, and that you don't stop or change your medication regimes without advice from your GP.
Brilliant, you answered my question there. Thank you.
Just a quick question. Somebody's just said that we've not mentioned fibromyalgia. How does the pain with that, is all that you've said relevant to fibromyalgia pain?
I would say definitely, if not more so. Medications are spectacularly hopeless for most people with fibromyalgia, unfortunately, and it's the mainstay of treatment for that is going to be lifestyle advice and DIY measures, which we're coming on to shortly. I believe some people find medication helpful for fibromyalgia in some way, but it's a problem with pain processing in the brain.
Thank you. And there's another question about, how do I get referred to a pain clinic?
Through your GP. If at first you don't succeed, try again.
And then at what point do I accept a knee replacement?
That's a good question. Oh, that's a completely different topic, isn't it? We're going to cover that in another webinar entirely. But a knee replacement is done for pain predominantly. It's not done for function. It's done because of pain. So if you have tried all of the above and nothing works, and your pain is unmanageable, and the surgeon thinks you will benefit from a new knee, then definitely think about that.
And watch our next webinar, which will be about, hopefully, about surgery. We'll let you know when it's coming up. Okay, so I think it's on to the next section. What else can you do to help with pain? Martin, did you want to answer that turmeric question first?
Yes, quite quickly, because there are, quite recently, and in 2018, there is a paper published in the British Journal of Sports Medicine, and they have looked at a vast array of some of the dietary supplements offered to people with osteoarthritis. And in fact, the title of the paper is quite nice. It's saying that, what do I recommend my patients who has got osteoarthritis? Now, to cut the long story short, things like glucosamine sulfate, is a flat no, because they are finding, the efficacy is not very good, despite, some people continue to do them, which, I certainly have got no issues with that. Again, is going back to the placebo side of things, and placebo effect is extremely powerful as a management of osteoarthritis. But other things like turmeric, MSM, and some of the other like more sort of newer dietary supplement. And in fact, the issue with that is, they studied it at 3 months, and then 6 months, and then 6 months and longer. Turmeric, I'm just single that out. It seems to be providing some sort of effect round about 3 months, and then everything after 6 months, the effect tend to die down. So it could well be there is an element of placebo effect there as well. But on the whole, turmeric, if you are using it as a supplement, it doesn't, the bioavailability to the body is actually quite poor. That's why you do get things like, mix it up with with black pepper, or or drink it with a full fat milk to try to enhance that. Now, nowadays, they're looking at things like nanoparticle technology, where it will make turmeric curcumin, which is the active compound, to go into the body a little bit more effectively. But at the moment, I know that there's a Dutch research group is looking into it. They have been working on it for a little while now, so I'm kind of eagerly waiting what the results are going to be. But I think at this standpoint, if you want to try turmeric, I would say to cook with it rather than using it as a supplement.
Thank you, Martin. Okay, so we're definitely moving on to the what can we do next? What's the much more bit of our webinar today? So first of all, we're going to ask Catherine, I think, and this is a question that somebody's given as well as a question that we were, hopefully you were prepared to answer, but it hurts to exercise. What can I do?
Okay, so I've just moved my slide on just there. Exercise is difficult, isn't it? Because we remember back to the last time we did some exercise, the last time we went to the gym or we took the dog for a walk, and inevitably we see ourselves as that young, fit, healthy person that we remember being before we developed a long-term pain condition. So our bodies are very good. I used to be able to cycle 10 miles, or I used to be able to swim 25 laps of the swimming pool. And so often we beat ourselves up over the fact that everyone tells us that exercise is the right thing to do. We may well have had poor quality interaction with physiotherapy services. We've been given a sheet of instructions or exercises where the person in the pictures appears to be in a leotard and be hypermobile and double jointed. And I spoke to my father, who had a knee replacement not all that long ago, and the first thing said, lay down on the floor and do these exercises. And he's, well, if I'm going to lay down on the floor, I'll never get up. So it is about trying to find things that for us are helpful. The word exercise can turn people off. I've done education sessions where you mentioned the word exercise. Patients put on they turn off their cameras, and that's the point. They run away to go make a cup of coffee. Exercise for some of us is frightening. It puts that threat back in our minds of exercise means hard work, it means gyms, it means leotards, and I'm not doing it. And if you could see anything more than my head and shoulders on this webinar, you'd know that exercise is not my most loved of activities. So I think the most important thing is, first of all, let's not call it exercise, let's call it activity. I'm very motivated. If I want to go to the park with my children, I'm motivated. If I want to walk the dog and do the gardening, but take me to a gym full of young, fit things, and I won't go. So why do we want to exercise? We know that actually, although it is very common when you first do some exercise, you are likely to get some muscular pain from doing that exercise. That's normal. That would be normal whether you had arthritis or whether you had nothing at all. If you're doing your activity or exercise for the first time, you will get some transient muscular pain. But we know that eventually, as the muscles get stronger, you get better support for your spines, your joints, and you will improve that alignment, which in turn gives you confidence and moves around. We know that it's really good for everything else. It's good for our cardiovascular system, our respiratory system, all the other bits that all join us all together. In the right amount, it reduces the joint stiffness, and most importantly, it puts those positive things back. It improves quality of life, it improves our well-being, it develops friendships and confidence and all of those sorts of things. But the absolute key to it is about starting at the right level. Because if you, and the risk, when we talk about the sort of psychology, is the risk that we we overdo things. We remember the fact that 15 years ago, I could get on my bike and ride 20 miles. But since then, I've got older, I've developed a condition, I can't do that anymore. And so most of us overdo it. We pay for exercise, we pay for swimming classes. If you're going to spend £6.50 going in the local swimming pool, you want to make sure you get the most out of it. So you do too much. Again, it's that too much is the problem. I think importantly, thinking about exercise as something that is done little and often, and something that involves our functioning, thinking brains as well is really important. There's lots of evidence and information about exercise and how important it is for all of the systems in the body. But there's also a lot of evidence about how it affects our mood, our thoughts, our feelings as well. So that's really, really important.
Thank you, Catherine. I just want to check that everything we've said is related to people with rheumatoid arthritis as well as osteoarthritis.
Absolutely. With certainly, within pain clinics, we see patients with all different types of pain, and all this advice is really, really important to share with everybody that's got any type of long-term pain condition. So yes, definitely.
Okay, thank you. Wendy, is there anything you want to ask?
No, I would totally agree with that last point that Catherine made. I think that's incredibly helpful. It's basically use it or lose it, really, isn't it, with exercise? So
yeah. And there aren't I think often one of the questions we're asked in clinics is what exercise should I be doing? The ultimate is it's got to be what you enjoy. Because it's not doing 6 weeks of physio exercise to get better. It is about a lifestyle change to what activity you're going to do that you're going to live with long term. So it's got to be something that, it's got to be something that you enjoy. And so, there's no point in recommending swimming or water aerobics if you're phobic of water.
Definitely, thank you. And I just noticed that Lee, one of our volunteers, has just put a message on there about saying chair-based supported exercises and bands are great. You can do them at work and at home. Yeah. Or even in a cafe or wherever you are. And one of the things that Arthritis Action does is Martin does occasionally runs some exercise classes online. We are working with an organisation called Good Boost, who we're trialling an app with to see if exercise on the app actually works, and it's bringing people together to do that. We can tell you more about that later. We have some chair-based exercises on our website, so you can look at those and check out on there. We've got a whole section on exercise. And we've also got sections on other things. We were going to talk about hypnotherapy, but we haven't got time to do that now. So we'll have to look at that again at another time. So I'm going to pass over to Martin, but thank you, Wendy, and thank you, Catherine. You've been amazing. Thank you.
May I just quickly say something about exercise, from a strength and conditioning point of view? I know that people might feel that, I absolutely, agree with you, Catherine, with that sheet of paper, with all the exercises, and it would just scare patients, no end. But, some movement is better than no movement at all. So if you find that, if you are doing a particular exercise for 10 times, that is going to aggravate your pain. I think, there are a few things that we need to remember. That pain doesn't equal more damage. And secondly, the movement itself will help to re-educate the central nervous system, where, where it will help to dampen down some of the pain signals. And finally, with the movement that you have been prescribed to do, it will help to strengthen your muscles, which is part of the powerful scaffolding that's going to keep your joints together. So if you feel that doing something that is more that's going to hurt you, then scale it down. Do it maybe 3 or 5 times, and then eventually your body will agree with you to do a little bit longer repetition of a particular movement. Okay, so we are now going to look at some questions. Right, I'm going to go through the Q&A box. Okay, I have a question here, experts. I have lower back pain, disc problems touching my sciatic nerves, goes down my leg to foot, pain all the time, very tired. I'm interested in some kind of action to help. Have tried many other things, but it sounds as though nothing seems to work for this lady here. Any quick advice for her, please?
Yes, I have a similar problem, and for me, I do. You can do self-hypnosis, but you need to be taught how to do it by somebody who's a clinical hypnotherapist, and you can contact them looking at the British Society of Clinical Hypnotherapy, the BSCH, and they, if you get one of those people, talk to them, get them to teach you self-hypnosis, and you can do it yourself, and it just helps. And yes, it is tiring, and yes, it is painful, but it can be, you can find a way to make it easier.
Are there any alternatives to oral anti-inflammatories as I am allergic?
I guess that sort of, we've covered a lot of that, really, haven't we, in the alternatives really to pain management. If you get asthma with anti-inflammatories, you probably shouldn't be using them at all. If it's just that your tummy's a bit sensitive, you can try rubbing on anti-inflammatories, can sometimes be helpful for the joints. And all of the advice that we've included so far, really.
Now, I have a question in relation to chili cream, capsaicin cream. Mary was asked, has anyone tried that?
I'm sure lots of people have tried that. Go for that, Catherine. It was in fashion a while back, wasn't it? It's gone out slightly.
Yeah, so I think it's still around, and I think it still has its uses. I think there was a supply issue for about 18 months. And again, I think it has probably the same properties as rubbing on any other cream. There is some evidence around the use of chili, the capsaicin being useful. I think that the downside is that it's quite, in the cream form, it's quite difficult to apply regularly. It doesn't really work if you only use it once or twice a day. It needs to be applied 3 or 4 times a day, and make sure that you wash your hands in between time, because it does contain a very active chili or capsaicin component. I'm suspicious about the rubbing action. I think is and the pleasurable warmth that it gives, I think, is probably the biggest bonus.
A pain consultant once told me there's a good way to actually apply capsaicin cream is to use the spoon, the back of the spoon, put a pea size at the back of the spoon, and then just rub it on the effective area. That way, you're avoiding all sort of like hands contact to the area. And I thought that is quite
good idea,
quite a good way to apply it. But yes, Catherine, it is you have to apply it several times a day, and it's not something that you can apply once and see the magic. And it does take about 6 to 8 weeks to see any sort of effect as well. One final question, I'm conscious of the time. Autogenic training. Any of you have got any sort of any input in relation to that? Autogenic training?
I don't know what that is.
No. can't say as I do. I presume it's to a look at trying to train our brains differently. So I couldn't comment on that specifically. Yeah, it might have to be something that we answer. I've just briefly had a quick look. It talks about it describes it as a relaxation technique that uses exercise to disconnect or move away from pain. So I suppose we could talk about psychological well-being and relaxation. So again, we know that if our muscles or our joints are tense and we are cross or frustrated, we know that pain is likely to be, the experience is likely to be greater. And we know that relaxation is the converse of that. So if we can relax, we know that our relaxed state can take over. And I think it plays a very big part in some people's management of their long-term condition. If I just direct you to this slide, just at the bottom here on the right-hand side, our firm belief is that there are lots of things that can help you manage pain, and relaxation is in that, but also things like mindfulness. And so I wonder, so autogenic training, if you looked at mindfulness, and really trying to be in the moment with where you're living life as now, rather than what used to happen and what might happen in the future, is a very healthy way of looking at managing pain as a long-term condition.
Yeah, definitely. And I've just looked it up as well to check. But if you go onto the Arthritis Action website, we have what's called a self-management resource. Our SMR, they're short videos, and we've got one for physical things and one for mental things. And you'll find on there that Martin and I actually did a relaxation technique. So if you want to, go on there and have a look and try it. And also, when my voice is working properly, there was a relaxation that you could just put in your headphones and just listen to it and relax yourself. And definitely agree with what Catherine's just said, that relaxation does actually help the muscle and it relieves the pain.
Thank you. Right, thank you. Well, I just looked at my clock and didn't realize that, the time just flew by. So thank you so much, Catherine, Wendy, and Heather. This concludes our webinar on pain management. If you would like any more information on the subject or on anything else related to arthritis, please visit our website, www.arthritisaction.org.uk. We have a number of useful resources and will help you self-manage your condition, including detailed information on exercises, dietary information, well-being resources, and tips on staying connected. A video of this webinar will be made available on our YouTube channel shortly. We will send you an email with a link to the recording once it is available. All that is left for me to say is thank you to Catherine, Wendy, and Heather for answering our questions. And thank you to all of you that joined us on this webinar. We hope you stay safe and healthy, and we look forward to hearing from you soon. Bye-bye.